Assalamu alaikum wa rahmatullah. I would like to thank the Saudi Society for giving me this opportunity today to present. And I would like to thank also Prof. Hassan Yazishi for this nice presentation. So without further delay, I have nothing to disclose in this presentation. In this presentation, my objective will be about the genetics in Behçet disease, the pathogenesis, as well as the therapeutic options in Behçet disease. Now, we know Behçet disease is a variable vessel vasculitis that could affect the large and medium, as well as small vessel blood vessel. Small vessel, it's associated with the variable manifestation, most commonly recurrent oral and genital ulcers. The prevalence is highest in ancient Silk Road, with Turkey is the highest country with the prevalence of 370 cases per 100,000 patients, typically presented between the age of 20 and 40, but it's more severe in young male patients. The first genetic association was described in 1982, in which HLA-B51 was described with Behçet disease. And recent meta-analysis showed that this association reached up to 72%, and it's lower in North American population to 39%. Genome-wide association study also confirmed this finding, and they found that also lesser extent of association of interleukin 10, 12, 23 mutations. Those variants appear mostly with patients from Turkey and Japan. Other association with the polymorphism, including the ERAP-STAT and KLRK gene. Now, the countries with the highest prevalence appear in dark red discoloration or color, and as we can see, the frequency more than 15% in our country, Saudi Arabia. Countries with the horizontal line represent variable data based on variable studies. Now, what about our population data from Saudi Arabia? First study was done or conducted by Dr. Al-Dal'an and his group. They found HLA-B51 was positive in around 61 patients out of 130, that represent around 72% compared to control. In another study by Dr. Uqaili, they found that HLA-2631B51 was associated with increased risk also of Behçet disease, and HLA-B15 was actually protective in Saudi patients. And by Dr. Yaqoubi, he conducted also another study, found that again HLA-B51 was found in 76% of the patient compared with control. Now, what is HLA-B51? HLA-B51 is a protein that found on the outer cellular surface in all cells except the trophoblast and the erythroblast. It's responsible for antigenic attachment and antigenic presentation to the cell. Now, the area responsible for the coding of major histocompatibility is the short arm of chromosome number 6. And we know that HLA, it's either class 1, 2, and 3. Class 1 is the most important for us now, which is HLA-B associated with Behçet disease. Now, in several data, there is an association or interaction between HLA-B51 as well as the ERAP1. What is ERAP? It's endoplasmic reticulum aminopeptidase. Now, what is this mechanism? If you look to this slide, we can see that the ERAP is responsible for trimming of the antigen peptide before it's uploaded to the HLA-B51 that will trigger the inflammatory cascade. Now, if you have a variant or a patient with a lower activity of ERAP, this will result in abnormality in the trimming. And this abnormal antigen will be uploaded to the HLA-B51 and triggering an inflammation that lead to the activation of natural killer cells as well as T cell disturbance. Now, the similar concept also was found in our patient with HLA-B27, i.e. SPA patient. They also have an interaction with the ERAP1 gene. In this process, we call it epistasis in medical science. Interestingly, they found that HLA-B27 also was associated with increased odds ratio, slight increased odds ratio in patients with Behçet disease. And also, another important or interesting finding, patients with the double positive HLA-B27B51, they have a benign course of Behçet uveitis compared with positive negative patients. Now, as I mentioned, the interaction between the ERAP and the HLA-B51, a process named as epistasis. And as we can see, if both are positive, the odds ratio for Behçet disease is high. If we look for another disease like psoriasis, HLA-6, CW6, coexistence with the ERAP1 gene also increase the odds ratio for psoriasis. So the concept of epistasis is there. So this interaction will lead us to what we call it major histocompatibility related diseases or major histocompatibility pathways. This disease or group of disease in which any physical stress that happen to our outer barrier or inner barrier will lead to significant inflammation. So inner barrier, like what we see in oral mucosa or small intestine in patients with Behçet disease, or outer barrier like inner barrier like the spine and the enthesis that will lead to activation of inflammation and arthritis and spondyloarthritis. Now let's move now to compare the major histocompatibility related diseases and the autoimmune disease in general. Now if we look to this table, first we will find that the major histocompatibility related disease does not have a female predominance, while with the autoimmunity, more female predominance. Moving to the genetics, and we demonstrated that before, major histocompatibility 1 is related to our group of diseases, while autoimmunity, it's related to major histocompatibility class 2. Joint disease, sites of any mechanical stress like enthesis, spine, or arthritis is associated with major histocompatibility related diseases, while in autoimmune disease, it's polyarticular and synovial. Another important finding, if we look to the therapy, major histocompatibility related disease respond to the anti-cytokines but not to B cell depletion. While with the autoimmunity, it may respond to both anti-cytokine and B cell depletion. So this was presented by Dr. Takidi on the latest ACR, in which again they found or they look for the common ground between Behçet disease and the spondyloarthritis. And as we can see, the association between Behçet disease and psoriasis, the common area in skin involvement is neutrophilic infiltration. Another important finding or common association is irritable skin. We can see Kopner phenomena with psoriasis, and we can see positive pathology test with the patient with the Behçet disease. Look also for the common medication in between both or that treat both. So if there is an overlap, this is something we need to address it in the future. Now, moving now to the pathogenesis in a patient who is susceptible with a streptococcal infection or important dysregulation between the oral and gut microbiome or molecular mimicry with the heat shock protein. In genetically susceptible patient, this will trigger a cascade of inflammation, activation of neutrophils, lead to the release of neutrophil extracellular traps that cause the direct damage, natural killer cells activation with more balance toward NK1 that lead to inflammation, activation of gamma delta T cells, and inflammation. Now, what are our therapeutic options in Behçet disease? First, the colchicine, our old friend, was implemented in the EULAR 2018 as a first-line treatment for a patient with a mucocutaneous manifestation as well as acute arthritis. It's worked with the several mechanisms of actions, including inhibition of innate immunity. Colchicine shown to be effective mainly in genital ulcer based on this double-blind placebo trial with the nodular skin lesion, mostly in women, with the lesser extent to work in men. And there is a controversy regarding the use of oral ulcers. So what happens if I have a patient with oral ulcer that is not responding? Old friend, thalidomide, a randomized double-blind placebo-controlled trial study conducted in Turkey involved around 96 patients with the dosage of 100 and 300 milligrams. Both doses showed decrease in the oral and genital ulcers as well as follicular lesions, so mucocutaneous lesion. But look for the side effect, severe polyneuropathy. A newer medication, lenalidomide, but it's reported only in 3 cases. It's also effective in mucocutaneous manifestation. Moving to azathioprine. Azathioprine, since 1990, by Dr. Hassan Yazici and his group, They conducted this study, it's a randomized controlled trial, showed that azathioprine was effective as a first-line treatment in a patient with Behçet uveitis combo with prednisone. It's also showed some efficacy or decreased frequency in oral and genital ulcers. What about cyclosporin? 3 randomized controlled trial. The conclusion, superior to colchicine in decreasing ocular attack, superior to cyclophosphamide in preserving visual acuity. But it's not effective in mucocutaneous manifestation as a monotherapy. It should be combined. But be careful of the long list of adverse events, and it's not useful for neuroBehçet. Apremilast, phosphodiesterase inhibitor that can be used also with the patient with the psoriasis. It inhibits the conversion of cyclic AMP to AMP, so increasing the cyclic AMP will act as a protective from an inflammatory cascade. Now, the finding with apremilast, the first finding is compared with the placebo with the decreased oral ulcer at week 12, and it was sustained up to 68 weeks based on the RELIEF phase 3 trial. It's also improved the quality of life and disease activity. So what about the other domains? This is a meta-analysis was conducted by a Japanese group, and they found that if we look for genital ulcers, there is a significant improvement at week 12 and week 24, but we don't have an extension or more data after that. What about the skin manifestation, other skin manifestation? Again, there is a good response at week 12 for a patient with erythema nodosum, a patient with the folliculitis, but with overall skin manifestation, it was not that good. And why is that? Possibly related to lack of standardized method to assess the skin disease in patients with Behçet disease. Again, for arthritis, and the data is just only up to week 12, we can see a good response with the apremilast. Now, moving to another chapter, the use of biological treatment in general. So first, I want to present this study, a retrospective that includes around 250 million patients to identify patients who are treated with the non-FDA approved biological treatment for the period between 2013 and 2020. They identified around 12,000 patients with the Behçet disease, 75% were female, and as you can see, the most common medication used was rituximab. Anti-TNF. Now, anti-TNF, we have a few, just maybe 1 or 2 randomized controlled trial, but it was implemented in the guidelines of EULAR guidelines in almost all domains for the treatment of Behçet disease, but actually not the first line, as we know. This is a narrative review that includes the 3 most important anti-TNF medication, infliximab, 325 patients, etanercept, 37 patients, and adalimumab. As you can see, a variable response, but a weaker response for etanercept, and as we know, it's not that effective in patients with uveitis, and this is expected result. All patients with in this study are inadequate response to immunosuppressive treatment. And as I mentioned, just only 1 randomized controlled trial for etanercept, and they conclude that the combination treatment of anti-TNF with other immunosuppressive treatment was superior. This is another study for refractory uveitis. They include around 100 Caucasian patients, and they found that 78 patients respond at around 3 years of continuous treatment. As you can see, the optic coherence tomography improved, retinal vasculitis incidence reduced, as well as the mean prednisone usage also was decreased. A concept, can we stop anti-TNF after a period of time or not? Now, in this study, they treated 46 patients with the anti-TNF treatment up to the end of 2016. Those patients underwent filtration, and 29 patients were able to stop the treatment, which is the anti-TNF. Sustained remission was achieved in around 12 patients, while in 17 patients they relapsed. When they retreated them again, 4 only, they achieve sustained remission. So the total may be around 60% of the total patient, which is the 29 patients, achieve remission. Now, moving to another biological treatment, the interleukin-1 inhibitor, anakinra and canakinumab. It was studied in the treatment for uveitis and retinal vasculitis. Small studies with an excellent p-value with improvement of the retinal vasculitis compared with the baseline. Tocilizumab retrospective study, and I want to just to tell you that the level of evidence here is just only scattered based on small data. Tocilizumab, 7 patients in this study with mainly arterial lesions that include aneurysm, stenosis, occlusion, and large blood vessels. All patients were on steroid and immunosuppressive treatment after around 1.5 year complete resolution. Effectiveness of tocilizumab, a systematic literature review, and I know the concept that systematic literature review is not that great evidence, but we don't have enough data in Bahjat. So we identified, or they identified 47 patients with the refractory disease. 24 out of 25 patients responded to the treatment, which is the tocilizumab. Neurological manifestation, total improvement in 6 out of 6, vascular 7 out of 7, and amyloidosis in 2 out of 2. But it was not effective in controlling mucocutaneous manifestation. And they conclude the same in this paper. Now moving to IL-12/23, ustekinumab, a pilot study from France for the treatment of oral manifestation. 70% achieved remission. Moving on to a larger multi-center prospective open-label trial that involved around 30 patients with active oral ulcers resistant to colchicine, we can see the number of lesions improve at week 12 and week 24 with a significant p-value. So ustekinumab, it can be useful. What about IL-17, secukinumab? The most important, we have 3 randomized control trial, phase 2 trial, that involve around 118 patients. And the primary endpoint was preventing ocular exacerbation by week 24. They tried even a higher dose, 300 milligram every 2 weeks with the secukinumab. Failed. Did not work for uveitis. Now, in a summary of all of these biological treatment, we can see that IL-1, anakinra, canakinumab, and givelcumab were useful as a treatment for uveitis, interleukin-6 inhibitor for neuroBahjat, uveitis to a lesser extent, and vascular Bahjat. But be careful, it was not effective for arthritis as well as mucocutaneous manifestation. IL-12/23 ustekinumab mucocutaneous manifestation was effective, as I demonstrated in the previous studies. Interleukin-17 was not effective for uveitis, but in mucocutaneous manifestation, there are smaller studies that showed some efficacy. So in conclusion, Bahjat disease is a polygenic disease that's associated with the multiple interaction. The concept of epistasis is there. But are these genes associated with severe disease or refractory disease? The answer is no. And finally, now our treatment target is toward our treatment option now toward the attack or targeting innate and adaptive immune system to reach remission. And thank you for